Welcome to this overview of the computer-based case simulation brought to you by Roadmap to Residency. The case simulation is the part of your licensing exam where you manage a patient in a realistic clinical environment instead of choosing a letter. Many strong students lose points here simply because the format is unfamiliar. Our goal today is not to reteach medicine. It is to teach you how the simulation works and how to play it well. We will cover what it is and how it is scored, how to write orders and advance the clock, the most common pitfalls, and the best practice resources. Have your primary review book and your case simulation practice software ready alongside this video. Here is what we are going to cover today. First, you will understand exactly what the case simulation format is and how it is scored, because the scoring drives every decision you make. Next, you will master order writing and the simulated time advancement that moves each case forward. After that, we will go through the most common pitfalls, learn how to avoid them, and point you to the best practice resources. This video assumes you already have baseline clinical knowledge from your review materials. We are here to sharpen the way you apply that knowledge inside the simulation, so the format never costs you points. Let us start with the format and the scoring, because everything follows from this. In the case simulation, you manage a patient over simulated time. You take a history, perform an examination, and order tests and treatments by typing them onto an order sheet in plain language. There are no answer choices. You build the plan yourself, then advance the clock to see what happens. For scoring, you earn credit for beneficial actions taken at the right time and in the right order, and you lose ground for harmful actions or dangerous delays. You are generally not punished for a reasonable confirmatory test. So the winning mindset is to think like a careful, efficient clinician, not a gambler guessing the one perfect move. Now the engine that drives every case, order writing and time advancement. To write an order, you type the action, such as a test or a medication, onto the order sheet, and the system recognizes it. Order your focused history and examination first, then the tests and treatments your leading diagnosis requires, and confirm each order is accepted so nothing is silently dropped. Time advancement is how you get results and reassess. When a patient is unstable, advance the clock only a short interval. When waiting on routine results in a stable patient, you can advance further. The most useful habit is to schedule a re-evaluation before any long jump forward, because the clock is how the case decides whether your plan is working. Let us recognize the 3 classic ways a case opens, because the opening tells you your strategy. The first is the unstable patient opening, where the first screen shows abnormal vital signs. Here you stabilize before you investigate. Airway, breathing, and circulation first. The right location next, then only a short advance of the clock. The second is the stable outpatient opening, with normal vitals and a focused complaint. Here you take a targeted history and examination and order only the few tests that confirm your leading diagnosis. The third is the hidden emergency, a routine-looking complaint that conceals a dangerous diagnosis. Here you order the one test that rules out the deadly possibility early, so you never advance past the window where timely treatment earns full credit. Let us work through our first practice case, framed as a multiple-choice question so the logic is clear. A 60-year-old man arrives in the emergency department with crushing chest pain. His blood pressure is low, and his heart rate is high, and the opening screen shows him in obvious distress. In the case simulation, what is the single most appropriate first action before you advance the clock? Option A, order a full set of routine labs and wait for the results. Option B, place the patient on the monitor, give oxygen, and obtain intravenous access. Option C, advance the clock by several hours to see how he evolves. Option D, transfer the patient to a general ward bed. Think about which one a careful clinician does first, and we will walk through it on the next slide. Let us break it down. First, spot the pattern. Low blood pressure and a high heart rate on the very first screen mark this as an unstable opening, and the case is testing whether you stabilize before you investigate. Now apply the rule. For an unstable patient, you place the monitor, give oxygen, and obtain intravenous access first, and only then advance the clock by a short interval. That is exactly option B, so option B is correct. Now eliminate the wrong answers. Option A waits on laboratory results while the patient deteriorates. Option C advances the clock straight through the danger window, which costs you the most points of any choice here. Option D moves an unstable patient to the wrong location entirely. The answer is option B, stabilize first. Here is our second practice case, this one about how far to advance the clock. You have already started treatment for a patient admitted with a serious bacterial infection. The patient is currently stable but not yet improving, and you still need to confirm the response to your therapy. In the case simulation, how should you advance the simulated clock next? Option A, advance several days all at once and then check on the patient. Option B, advance a short interval with a scheduled re-evaluation. Option C, do not advance the clock at all until every single result returns. Option D, discharge the patient now to save simulated time. Decide what protects the patient while still moving the case forward. Let us read the situation carefully first. The patient is stable but not yet improving, which is precisely the moment that calls for close monitoring rather than a long leap forward. The case is checking whether you reassess before something can go wrong. Now, why the short interval wins? Advancing a short interval with a scheduled re-evaluation lets you catch any deterioration in time to act on it. Compare that with the alternatives. Option A risks skipping right past a developing complication. Option C refuses to use the time advancement tool the case is built around, so the patient never gets reassessed efficiently. Option D abandons a patient who is not yet improving. The answer is option B, a short interval with a planned re-evaluation. Now the pitfalls, because avoiding them is where most points are won or lost. There are pitfalls of action. The biggest is ordering too much, since every unnecessary or invasive order can pull your score down, so order only what changes management. The second is a harmful action, such as a contraindicated drug, so order deliberately and confirm each order is accepted. Then there are pitfalls of timing and location. The biggest timing trap is advancing the clock too far and missing the window for a beneficial action, so reassess in short steps. The biggest location trap is leaving a patient in the wrong setting, so move them to the correct location early. Keep these 4 traps in mind and most of your lost points will simply disappear. Let us apply the pitfalls to a case. You are managing a child in the emergency department with a high fever, a stiff neck, and an overall very ill appearance, and you suspect a serious central nervous system infection. You want to maximize your score in the case simulation. Which sequence avoids the most common pitfall? Option A, advance several hours to gather every result and then treat. Option B, start empiric treatment now and then confirm with testing. Option C, order a long list of tests before giving any treatment. Option D, discharge the child with outpatient follow-up. Think about the timing trap we just described and choose the sequence that protects the patient. Let us spot the classic pattern. A very ill child with fever and a stiff neck signals a time-critical emergency, and the case is testing whether you deliver the beneficial treatment inside the window rather than letting the clock run while you gather data. Now know the key distinction. The correct approach is to obtain the key cultures quickly, then start empiric treatment promptly, and confirm the diagnosis afterward. Option A and Option C either advance time or pile on tests and miss the treatment window. Option D is frankly harmful for a child this sick. The answer is Option B, treat now and confirm next. This is the single most important pitfall to internalize, because timing errors are the most common way strong students lose points on the simulation. Let us consolidate everything into the habits that earn points. There are 5. Take a focused history and examination first. Order only what changes management. Treat time-critical conditions before you confirm them. Advance the clock in short steps and reassess. And move the patient to the right location early. Why does this matter in the simulation? Because the case rewards beneficial, well-timed and well-sequenced actions, and it penalizes harm and delay. Every one of these 5 habits adds beneficial actions while removing chances for harm. Practice them until they are automatic, because under time pressure you will not rise to your knowledge. You will fall back to your habits, so build the right ones now. Let us finish with practice resources and where to learn more. The single best preparation is the official case simulation practice software, where you can run full, timed cases exactly as they appear on exam day. Pair that with your primary review book for the underlying management and rehearse order writing and time advancement until both feel completely automatic. To put it simply, stabilize first, order with purpose, treat time-critical problems early, and advance the clock in careful steps. For expert tutors and residency advisors, visit roadmaptoresidency.com. If this was helpful, please like and subscribe for more board review content. Good luck, you have got this.